Good afternoon, everyone. Our group will be discussing about infective endocarditis. So, for the background of the disease, infective endocarditis is a serious infection that affects the lining and valves of the heart. It is mostly associated with the infection of the heart valve. However, septal defects may be involved in some cases. It can also occur in patients with prosthetic or mechanical devices or to those who are intravenous drug users or IVD use. Bacteria are known to be the primary cause of infective endocarditis, but fungi and atypical organisms may also be responsible pathogens. So, infective endocarditis can be classified into two categories, acute and subacute. For the acute disease, it is more aggressive and characterized by high fever, leukocytosis, and systemic toxicity, with death occurring within a few days to weeks. This type is often caused by Staphylococcus aureus. For the subacute type, it is caused by less virulent organisms such as the viridans group Streptococci, producing a slower and more subtle presentation. Symptoms of subacute infective endocarditis includes weakness, fatigue, low-grade fever, night sweats, weight loss, and other non-specific symptoms with death occurring in several months. So for the general symptoms of infective endocarditis, persistent fever is the most common symptom present in patients with IE. Other symptoms would include chills, night sweats, weakness, dyspnea, weight loss, myalgia or arthralgia. Signs of IE includes fever as the most common sign, new or changing heart murmur, embolic phenomena, and skin manifestations such as the petechiae, splinter hemorrhage, Osler's nodes, and Janeway's lesions. Splenomegaly is also present and clubbing of extremities. For the risk factor of the disease, the most significant risk factor for infective endocarditis is residual valvular damage caused by previous attack of endocarditis. Other risk factor involves prosthetic heart valves, intravenous drug abuse, structural heart disease such as mitral valve prolapse with mitral regurgitation, and aortic stenosis. Congenital heart defects such as tetralogy of Fallot, bicuspid aortic valves, coarctation of the aorta, and patent ductus arteriosus. Host factors such as neutropenia, immunodeficiency, malignancy, alcohol, and diabetes mellitus can also predispose the patient to infective endocarditis.
Epidemiology of infective endocarditis. Infective endocarditis is now considered the fourth leading cause of serious infectious disease syndromes, following urosepsis, pneumonia, and intra-abdominal sepsis. Men are more commonly affected than women at a ratio of 1.7 to 1. Although IE occurs at any age, more than 50% of cases occur in patients older than 50 years. The increasing rates of IE in the elderly could be the accumulation of factors such as improved living standards, which indirectly increase the population with degenerative valve, hence leading to increasingly prosthetic valve surgeries in older patients. IE in children continues to be uncommon and is mainly associated with the following: underlying structural defects, surgical repair of the defects, or nosocomial catheter-related bacteremia. So this is the incidence of infective endocarditis according to age and sex in a French population study of 497 patients. Zenith at 194 cases per million in men aged 75 to 79 years. Healthcare-associated endocarditis includes nosocomial, and community IE after a recent hospitalization or as a consequence of long-term indwelling devices. So the two most common pathogens related to these are Staphylococci and Enterococci. The risk of IE can be as high as 10% in cases of catheter-induced S. aureus bacteremia. Common organisms associated with IE in HIV-infected patients are S. aureus and Salmonella, while in IV drug abusers with HIV are the fungal microorganisms such as Candida albicans, Aspergillus, and Cryptococcus neoformans. With the increased use of mechanical valves, prosthetic valve endocarditis accounts for 10 to 30% of cases in the developed world. Patients who are IVD use or the intravenous drug users are at very high risk of acute endocarditis because numerous needle punctures give aggressive staph bacteria many opportunities to enter the blood through broken skin, with 150 to 2,000 cases per 100,000 persons per year, most being younger adults. Majority of cases are caused by gram-positive organisms. This consists primarily of streptococci, staphylococci, and enterococci. Consideration of gram-negative, fungal, and other atypical organisms must be taken into account, particularly in certain patient populations. So in this slide, it shows the microbiologic etiology of endocarditis in 1,558 patients, 58 hospitals in 25 countries between June 2000 and September 2005.
So this is the pathophysiology of infective endocarditis. So this is the diagram, and the pathophysiology of infective endocarditis, it comprises of at least three critical elements, which is the preparation of the cardiac valve for bacterial adherence, addition of circulating bacteria to the prepared valvular surface, and the survival of adherent bacteria on the surface with propagation of the infected vegetation. So in order to further understand this diagram, so it includes pre-existing endocardial lesions or inflammation that would lead to endothelial cells and platelet activation, coagulation, and thrombus formation. So repeated bacteremia leads to pathogens attachment to endocardial thrombus through adhesins. Colonization and invasion of the myocardium occurs, resulting in the formation of infective vegetation, wherein the pathogen would multiply and escape from the host defenses. And the vegetation becomes massive, destroying the valve tissue, leading to embolic events, abscess formation, and valve dysfunction. So, trauma will produce an alteration in the endothelial cell, which can cause disruption of the surface and deposition of the platelets and fibrin, or other phenomena that render the surface susceptible to colonization by circulating bacteria. Then some bacterial strains would adhere to the fibrin platelet matrix, and this can be blocked by antibodies directed against various surface structures. Vegetation propagation involves activation of the clotting cascade, and for some streptococci, this occurs partly via perturbation of the valvular cell to produce tissue thromboplastin, which results in the deposition and growth of a fibrin platelet clot over the rapidly growing bacterial colonies. For the laboratory test, the laboratory features include anemia, elevated white blood cell, and erythrocyte sedimentation rate is also elevated, microscopic hematuria, bacteremia. In patients with infective endocarditis, they have a low-grade consistent bacteremia with approximately 80% of cases having less than 100 CFU per ml. For the blood test, first one is the blood culture, positive result. One set gives 90% sensitivity and the remaining two sets at 8%. For the negative result, it indicates culture negative endocarditis and may yield less known microbes such as Coxiella burnetii and Bartonella spp. For the next blood test, it's the CBC, which is a non-specific test for infective endocarditis. So the red blood cell is low, which indicates anemia, and this occurs in majority of the patients. The white blood cell may also be elevated, which indicates acute disease. Normal white blood cells, however, indicate subacute infection. Elevated erythrocyte sedimentation rate naman is highly nonspecific and indicates the presence of inflammation.
Pharmacotherapy of the disease and algorithm of therapy. First one is antibiotic. It is a first-line treatment of ineffective endocarditis. First is antibiotic. So antibiotic is the choice of definitive antibiotic therapy. It's based on the causative microorganism and it is antibiotic susceptibility and whether it involves vulnerative or prosthetic. So other one is surgery. Surgery is a surgical intervention should be considered in patient with fungal infection. Infection with aggressive antibiotic resistance bacteria and also bacteria with respond poorly to antibiotics or in left-sided infections endocarditis caused by gram-negative bacteria, persistent infection with positive blood cultures after 1 week of antibiotic therapy, or one or another embolic events during the first 2 weeks of antibiotic therapy. So the next one is anticoagulation. Anticoagulation in patients with infectious endocarditis is controversial, particularly in those with mechanical valve endocarditis. Also, follow-up and patient education in patients with a history of infectious endocarditis. Also may use the 3 set of blood cultures should be obtained from separate sites before antibiotics are initiated for febrile illness. So then the other one is antibiotic. So for the antibiotic therapy, as I said lately, it prolonged administration of intravenous antibiotics and has been mainstay of infective endocarditis treatment. So there are 3 types of therapy for antibiotic. The first one is empiric antibiotic therapy. It is chosen by the basis of one most likely infecting organism. And the second one is native valve endocarditis, or the NVE, has often been treated with penicillin G and gentamicin for synergistic coverage of streptococci. And lastly, the prosthetic valve endocarditis, or the PVE. It may cause by MRSA or CONS. So the next one therapy is the anticoagulation. It uses as a thrombosis. It is a key element of ineffective endocarditis. Anticoagulation with warfarin and coumadin is controversial, and patients who are treated with anticoagulation, it appears to have a higher rate of extracerebral bleeding. If an established reason for anticoagulation, example is deep venous thrombosis and also presence of mechanical prosthetic valve exits, and standard regimen of anticoagulation should be followed. So the next one is indication for surgery. So approximately 15% to 25% of patients with ineffective endocarditis eventually it required surgery. So surgery is often required for treatment of metastatic infections. An example of this is cerebral and other types of aneurysm and microabscesses of the brain and also in the spleen. So endocard is for endocardium, and also itis is inflammation. So there are 2 types for endocarditis, is the bacterial source and abnormal substrate. For the bacterial source is ineffective needle and open wounds, cardiac devices and surgery, intravascular catheter, and also dental procedure. So for the abnormal substrate, it is used as prosthetic valve and native valve damage, just like rheumatic heart disease, mitral valve prolapse, aortic valve disease, congenital heart disease. And for the bacteria source, it runs in the bacteria in bloodstream, and for the abnormal substrate, it occurs in the thrombi or platelets and fibrin. So the next one is indication for surgical intervention in patient with native valve endocarditis are as followed by: first is congestive heart failure refractory to stand medical therapy, also fungal ineffective endocarditis except that caused by histoplasma capsulatum, also persistent sepsis after 72 hours of appropriate antibiotic therapy, and also recurrent septic emboli, especially after 2 weeks of antibiotic therapy, and also rupture of aneurysm of the sinus of Valsalva. Also conduction disturbance caused by septal absence. And lastly, kissing infection of the arterial mitral leaflets in patient with endocarditis of the aortic valve. So for the overall treatment, patient with endocarditis are treated with antibiotics. Some may be need for surgery to fix or replace to clean up any remaining signs of infection. So for the medication of this, it includes the type of medication. It depends on what causing the endocarditis. High doses of IV antibiotic are usually used to treat endocarditis caused by bacteria or virus. Lastly, endocarditis is caused by fungal infection. The patient must take antifungal medication. Some people need lifelong antifungal pills to prevent endocarditis from returning. And also, treatment, it includes isolation of infecting pathogen and determination of antimicrobial susceptibilities, followed with high-dose parenteral and bactericidal antibiotics for an extended period. So also, as I said lately, that surgery, it includes in the treatment of ineffective endocarditis. So surgical replacement of the infected heart valve is important adjunct to endocarditis treatment in certain situations. Example of this is patient with acute heart failure. So for the medication of the endocarditis or acute endocarditis, first is beta-lactam antibiotics such as penicillin G or ceftriaxone, napsilin, and ampicillin. It remains the drug of choice from streptococcal, staphylococcal, and enterococcal endocarditis. And also, it includes the aminoglycosides antibiotic. It's also essential to obtain a synergistic bactericidal effects of the treatment enterococcal endocarditis. And also, adjunctive aminoglycoside also may decrease the emergence of resistant organism. An example of this is prostatic valve endocarditis caused by coagulase negative staphylococci, and also has then the piece of clinical and microscopic response. Example of this is some streptococcal and staphylococcal infections. And also, vancomycin is reserved for patient with immediate beta-lactam allergies and the treatment of resistant microorganisms. And lastly, antimicrobial prophylaxis. It is used to prevent infective endocarditis for patients who have high risk, such as person with prosthetic heart valves, before a bacteremia causing procedure. Example of this is dental extraction.
Complications of the disease. So a variety of complications may be present in any certain patient. Some patients present with 1, 2, 3, or even more complications that are all happening simultaneously. So actually, it's more common than you think. So almost half of patients have at least 2 complications, and 14% of patients have 3 or more complications. So you might be thinking, well, 3 complications, is that really a thing? Well, yes, it is. So for example, just to kind of give you an idea of what these complications or like 3 or more complications look like, an infective endocarditis patient could have an emboli, okay? And at the same time, they could also have a metastatic abscess or a mycotic aneurysm and a cerebral hemorrhage. So that's already 4 possible complications. So another example with just like 2 complications, patients with hematogenous dissemination, they can also have an emboli again at the same time, or they can simultaneously have musculoskeletal complications or symptoms. So it really just depends on the patient. So these are broken down into 4 main categories. So we have intracardiac infections and local spread, hematogenous dissemination, musculoskeletal complications, and immune-mediated damage. Okay, so diving a little bit deeper into the 4 categories of complications. So let's start off with intracardiac infections and local spread. So if there's something that I would like you to remember from this category, it would 100% be congestive heart failure. So among actually all of the complications that I'm going to be discussing or mentioning, I would say you should really keep congestive heart failure at the top of your list. So congestive heart failure is the leading cause of death in terms of complications in infective endocarditis patients. So it's actually considered the most important complication of infective endocarditis because it has the greatest impact on the prognosis of our patient. So in most cases, patients have moderate to severe heart failure. They're considered an NYHA class 3 or 4 status. So the timing for early prophylaxis and treatment really influences prognostic significance. So in a lot of cases with like these complications, the earlier the better. Now for cardiac abscesses, this is another fairly common complication, but this is most common in like acute cases of infective endocarditis. So this can actually happen anywhere in the heart, but most frequently cardiac abscesses occur at the aortic root. So actually 57%, just about 57% of cardiac abscesses occur at the aortic root. So just keep that in mind. And the infecting organism that is typically responsible for cardiac abscesses is Staphylococcus. So that's actually responsible for over 52% of cases of patients with abscesses. So you might be thinking, okay, well, big deal, it's just an abscess. Well, actually, occasionally, cardiac abscess can lead to papillary muscle rupture or ventricular septal perforation, or even purulent pericarditis if the infection infiltrates the myocardial wall. In some cases, it can actually spread to the adjacent structures of the body, which is actually what happens in 88% of cases. So cardiac abscess actually plays a significant role in increasing our patient's chance of mortality. Now, diagnosis is difficult, especially for smaller abscesses or like abscesses that are located on the anterior wall of the heart, or even mitral abscesses. So just keep that in mind. Moving on to embolization. So if we're talking like systemic embolization, this actually occurs anywhere from 13% to 50% of cases of infective endocarditis. Emboli may involve like the major arteries of the patient. Most often it affects the central nervous system, but it also has the potential to affect other organs like the spleen, the kidney, the lung, the liver, and the limbs of a patient. So systemic embolism is more common in like fungi-related infective endocarditis. And in left-sided infective endocarditis patients, they're actually more associated with hepatospleenal embolization or renal embolization. So the type of infective endocarditis or the causative agent of that patient's infective endocarditis actually plays a potential role in like the type of embolization that might occur. And in many cases of patients who, have IE and they also have embolization, they present with like stroke, meningitis, a cerebral abscess or brain abscess, and bacterial aneurysm. Next, we have mycotic aneurysms. So these are not as common in the grand scheme of infective endocarditis. However, they are a common complication of the hematogenous spread of infection. So like if a patient has systemic infection, especially those who also have atherosclerosis along with their infective endocarditis. Mycotic aneurysms could definitely happen in that case. But typically mycotic aneurysms result from like the diffusion of an infection into the vessel wall. So that's why sometimes it's called an infected aneurysm, because it's associated with an infection. So you may be thinking mycotic, okay, so that means fungal. These types of aneurysms used to be associated with fungal infections. However, don't be fooled. A majority of mycotic aneurysms are actually caused by bacteria. But potentially mycotic aneurysms could be bacterial, fungal, or viral in origin. So basically, if an artery is like blocked by a septic emboli, the wall could become necrotized and destroy itself basically. And then that develops a bacterial aneurysm. So this could affect the aorta, the brain, the viscera, or like the internal organs within the chest and abdomen of a patient. And also the limbs. These could all be involved in mycotic aneurysms. And these aneurysms have a high mortality rate, unfortunately, but this is because of its potential catastrophic rupture, but that could be prevented with the help of like early diagnostic techniques, more specifically like imaging. But as I said earlier, the earlier the better. You want to catch it as soon as possible so that you can help the patient with treatment sooner rather than later. And lastly, for this category, we have neurological complications. So it's a pretty broad subset, I guess you could say. But neurological complications develop in 20 to 40% of patients that have infective endocarditis. So this represents a really dangerous subset of complications, actually. So let's start off with talking about stroke, because this falls under neurological complications, of course. So we have ischemic and we also have hemorrhagic stroke. So these two are important neurological complications, and they actually occur fairly frequently in patients with infective endocarditis, most likely due to like uncontrolled infection in certain patients. Under this category, we also have hemorrhage. So cerebral hemorrhage can occur or will occur when the vessel is broken, especially in cases of like bacterial aneurysms or embolism. Now, there are multiple mechanisms for cerebral hemorrhage in infective endocarditis patients. So like just a quick example, it could possibly be due to a rupture of a mycotic aneurysm. It really just depends on like the underlying complications that patient has. And we also have subarachnoid hemorrhage. So this is rare, but it's a very dramatic neurological complication in infective endocarditis patients. And it's always, like not even almost always, it's always associated with an aneurysm rupture in the early phase. So some journals report that there's actually like a higher risk of mortality with intracerebral hemorrhage as opposed to subarachnoid hemorrhage, but that information is still being speculated, so take that with a grain of salt. And again, they also seem to think that this species of microorganism that's responsible for the infective endocarditis has some sort of relationship with the occurrence of brain hemorrhage. So actually data that has been presented in a certain investigation on infective endocarditis has shown that brain hemorrhages in about like 41% of infective endocarditis patients are actually caused by Staphylococcus aureus. Moving on to hematogenous dissemination. So as you can probably tell by what I highlighted, I would consider abscesses to be the star player in this category. So abscesses, this could really could occur potentially anywhere actually, but most commonly periannular, splenic, renal, cerebral, and sometimes metastatic. So it could actually also occur in like the soft tissues as well. So patients who present or develop abscesses, in line with like their infective endocarditis actually are more likely to undergo surgery than those who do not. So they have, I think, up to a 91% chance of undergoing surgery. And also with that, their in-hospital mortality rate is higher. So a prompt detection of complications often allows for an earlier surgical treatment, which represents the best way to improve the patient's outcome. Now, some abscesses do show some improvement with antibiotic treatment, but it really just depends on the type of abscess and how early they were able to catch it in order to see if it's able to still be controlled with just antibiotics alone. So I'm just going to shout out a couple of the types of abscesses because these would be like the two, more common types of abscesses that are more relevant in clinical practice today. So first would be periannular abscesses. So this is a relatively common complication of infective endocarditis. It actually occurs in up to 85% of cases, and it's associated again with a higher morbidity risk and mortality risk. Next would be a splenic abscess. So this is a bit of a less common complication of infective endocarditis. However, it's very interesting the way that it kind of changes up the treatment plan for our patient. So these patients present with abdominal pain, shoulder pain because of diaphragmatic irritation, or they'll even just present with a persistent fever. So the reason why I said splenic abscesses were so important was because patients with splenic abscesses cannot survive without surgery. So if a patient with infective endocarditis presents with a splenic abscess, it becomes the top priority. The splenic abscess is treated first. It's the priority over all other procedures they have planned for that patient. So I just thought that was interesting because it really affects the overall scheme of that patient's treatment. Next, we have toxic encephalopathy, so changes in brain dysfunction, cognitive abilities, variation in the level of consciousness and vigilance of our patient. Sometimes they present with delirium and confusion. And then we have purulent meningitis. So this complication is, again, not as common, but it is concomitant with cerebral abscess. So sometimes an intracerebral abscess can enter the subarachnoid cavity and cerebral ventricle and will invade the meninges. So this will cause purulent meningitis. So typically if Streptococcus anaerobis or Staphylococcus species or even mixed bacteria are found in the cerebral spinal fluid of our patient, it suggests that there was a broken or ruptured intracerebral abscess, and thus in most cases there's probably purulent meningitis. Okay, so moving on to musculoskeletal complications. So these occur in around 44% of infective endocarditis cases, and manifestations include spondylodiscitis, septic arthritis, and even osteomyelitis. So the microorganism, the culprit that is responsible for most, or actually all of these musculoskeletal complications would be Staphylococcus aureus, but potentially it's really any gram-negative organism, but again, Staphylococcus aureus is really highlighted as the one that is most frequently associated with these complications. So just a brief recap of what these complications are. So spondylodiscitis, it's associated with the primary infection of the intervertebral disc, so that's the discitis part, along with the secondary infection of the vertebrae, which is the spondylitis or the spondylo part, so spondylodiscitis. And this can actually lead to osteomyelitis, which I'll talk about in a little bit. And again, for spondylodiscitis, Staphylococcus aureus is the culprit really of this complication. It is responsible for over 50% of cases. Septic arthritis, again, a common cause of septic arthritis is also Staphylococcus aureus, and septic arthritis actually could lead to permanent damage. I know it might not sound super scary, but it could lead to permanent damage of the joint or sepsis, so it really should be taken seriously as well. And then osteomyelitis, so this is the infection of the bone, so this could be like bacterial or fungal in origin, but this is very serious and very painful at the same time. So osteomyelitis, I guess in more severe cases or even in moderate cases, really needs surgery to like drain the infected area and remove portions of the infected or like necrotized bone and tissue. And then after that, they'll start the patient on like a round of intravenous antibiotics. So sometimes it leads to amputation, especially in our patients who also have diabetes or poor blood circulation along with infective endocarditis. And osteomyelitis actually spreads fast. So within a week, within 7 to 10 days, it can spread all around the patient's body. So typically for this, they will give the patient like clindamycin or some sort of beta-lactam antibiotic. Now in patients with like septic arthritis or osteomyelitis, honestly, sometimes it can never completely go away. So sometimes it will like lie dormant and then return after a few weeks once the treatment is over. So unfortunately, recurrent infection is actually a very common complication of both osteomyelitis and septic arthritis. And finally, we have our last category, which is immune-mediated damage. So this manifests as glomerulonephritis, splenomegaly, pericarditis, microvessel vasculitis, and sometimes arthritis. And immune-mediated damage in all of its manifestations are due to the cellular and humoral-mediated immune response of the body. So glomerulonephritis is the inflammation of the glomeruli of the kidney. So obviously if the glomeruli are damaged, your kidney cannot function properly. So this could potentially lead to like renal failure or kidney failure. However, in like current medicine, with antibiotic prophylaxis and therapy in like infective endocarditis patients, the incidence of glomerulonephritis has actually decreased by about 4.5%. But at least there's been a decrease, so that shows potential. Now for splenomegaly, obviously it's the abnormal enlargement of the spleen. So because it's enlarged, it obviously presents a risk of rupturing, which is another problem for a patient. And then for microvessel vasculitis, the inflammation of the blood vessels. So this could cause damage to the vital organs and tissues of the body. Now vasculitis can sometimes present or cause certain unspecific signs on the skin and mucosa of our patient. So this includes like hemorrhages on the patient's nail beds, bleeding spots with like a white center in the middle on the retina, so that's called Roth spots. And other times it presents on like the palms or soles of the patient. So if the patient has like painful nodules, that's Osler's nodes, and if it's painless but bleeding, then that would be Janeway lesions. So the pathogenesis for these complications can be caused by microemboli or microabscesses, especially in like the small vessels of the dermis. So typically if you treat the infection, the vasculitis will go away, but sometimes they'll prescribe the patient with like an NSAID to take care of the inflammation, or in other cases, corticosteroids. Okay, last section. So we have preventative measures. So for preventative measures for infective endocarditis, it really is mainly just prophylactic antimicrobial therapy. So the objective of prophylactic antimicrobial therapy is to diminish the likelihood of infective endocarditis in high-risk individuals. So antimicrobials used for this purpose really require the consideration of like the cardiac conditions that the patient has that might be associated with infective endocarditis, procedures that the patient may undergo that could possibly cause bacteremia, organisms that are likely to cause infective endocarditis, as well as the pharmacokinetics, spectrum, cost, adverse effects, and ease of administration of the available antimicrobial agents. So there are actually no prospective, like controlled human trials or studies that have demonstrated the benefits of prophylactic antimicrobial therapy in like high-risk individuals to prevent the development of infective endocarditis. More specifically, patients who are undergoing like bacteremia-inducing procedures. However, animal studies have shown benefit, which is why they are still implementing the use of prophylactic antimicrobial therapy in certain patients. So the beneficial effect of prophylactic antimicrobial therapy is unclear and controversial. But as I said earlier, animal studies have shown benefit, but they suspect that antibiotics may decrease the number of bacteria at the surgical site, kill bacteria after they've been introduced into the blood, and also prevent adhesion of bacteria to the valve. But regardless of the controversy about whether or not prophylactic antimicrobials should be used, infective endocarditis prophylaxis is actually recommended in select situations or circumstances, especially in patients with high-risk cardiac conditions. So the AHA released updated guidelines that kind of better define who should and should not receive antimicrobial prophylaxis. So the next two slides comprise what the AHA guidelines state. So one would be only a small number of cases can be prevented with antimicrobial prophylaxis, specifically for dental procedures. Next would be infective endocarditis prophylaxis should only be recommended for patients with high-risk underlying cardiac conditions. So this would be like prosthetic heart valve, the patient has prosthetic material that they used for like a cardiac valve repair, if the patient has a prior diagnosis of infective endocarditis, if the patient has had a cardiac transplant with a subsequent valvulopathy, and if the patient has congestive heart disease. Along with that, dental procedures, more specifically those that like involve the manipulation of the gingival tissue or like the gums, or perforation of the oral mucosa in general. In addition to that, invasive respiratory procedures, more specifically those that involve an incision or a biopsy. And lastly, invasive procedures that involve like infected skin, skin structures, or the musculoskeletal tissue of the patient. So these would be the procedures where the AHA really recommends prophylactic antimicrobial therapy in order to prevent the occurrence of infective endocarditis in that patient. And continuing the AHA guidelines, the third one would be prophylaxis is not recommended based solely on an increased lifetime risk of acquisition of infective endocarditis. So like you can't give a patient prophylactic antimicrobial therapy just because you think that they're, probably going to get it sometime in their lifetime. That's not how that works. And lastly, the administration of antimicrobials solely to prevent infective endocarditis is not recommended for patients who have undergone like a gastrointestinal or genitourinary procedure. Unless the patient has like an active gastrointestinal or genitourinary infection, in which case they would provide prophylactic antimicrobial therapy, but that would be directed against like enterococci. Now, this set of guidelines actually significantly reduced the number of patients that are eligible for infective endocarditis prophylaxis. They reduced the list of like cardiac conditions. They excluded a lot of these cardiac conditions, so they're no longer considered high-risk conditions. So for example, mitral valve prolapse, that's no longer included, so they no longer need antimicrobial prophylaxis. And just to make something clear, actually, in order for a patient to be eligible for infective endocarditis prophylaxis, the patient must meet the criteria for having both, again, the high-risk cardiac condition, and also they must be undergoing a specific procedure. So as I mentioned earlier, it's actually the first bullet point on this slide. So they can't give prophylactic antimicrobial therapy just because, this patient might possibly get infective endocarditis in the future because they have a high-risk cardiac condition. No, this patient needs to have the high-risk cardiac condition and has to be undergoing the specific procedure that is associated with inducing bacteremia. So even with appropriate infective endocarditis prophylaxis, only a small number of cases might actually be prevented with prophylactic antimicrobial therapy. So most cases of infective endocarditis are actually not from invasive procedures at all, but rather from bacteremia related to like daily activities that the patient participated in, like toothbrushing or flossing or even just chewing, and they accidentally like bit their lip or bit their cheek or something like that. So that's why they kind of cut down on giving prophylactic therapy prior to procedures. Now, another thing to note would be for patients who are undergoing procedures on skin or soft tissue, an agent active against Staphylococcus aureus should be considered. That should be administered to the patient. So, for example, like clindamycin or vancomycin, preferably an anti-staphylococcal beta-lactam would be used. Now, patients who are on like chronic antibiotic therapy, they should also receive infective endocarditis prophylaxis with an antibiotic from a different class than their pre-existing agent that they're already taking. So this is just to avoid encountering like antimicrobial resistance. So just keep that in mind, that there are certain specifications that we can kind of alter to fit that patient's specific case. Okay, and so now this is just a tabulated form of the various antimicrobial options for prophylactic antimicrobial therapy against infective endocarditis. So right off the bat, you see it in bold and highlighted. The preferred oral antibiotic would be amoxicillin. So for adults, that's 2 grams. And for pediatric patients, that would be 50 milligrams per kilogram. And you guys can kind of like browse through the table on your own, but I'm just gonna shout out a couple of important notes. So for patients who have a penicillin allergy, more specifically, those who have non-immediate hypersensitivity reactions to like penicillin or ampicillin, their options would be like cephalexin, clindamycin, azithromycin, or even clarithromycin. And you can see those listed on the table and like their various routes and their doses. But just keep in mind that I said non-immediate hypersensitivity reaction, because there's the non-immediate hypersensitivity reaction and then there's the immediate type reaction. So for like cefazolin or for ceftriaxone or cephalexin, these should be absolutely avoided in patients who are experiencing the immediate type reaction. Now, for patients who are unable to take oral medications, they recommend ampicillin, cefazolin, ceftriaxone, or clindamycin. And again, you can see the corresponding doses and routes on the table. So all of these antibiotics are given as a single dose 30 to 60 minutes prior to the procedure. Now, if vancomycin is the one that's being administered, then that should be given 2 hours before the procedure, but that's the only adjustment they make. But typically, they don't really administer vancomycin. And just in case, let's say they completely forget to give the patient some sort of antibiotic, or the patient forgets to take the antibiotic before the procedure, then it may be given within a 2-hour window post-procedure. So there are a couple of like special situations where they kind of alter the antimicrobial therapy. So if, for example, there is a suspected or there's a possibility that like established infective endocarditis exists before a certain procedure, then they'll draw blood cultures from the patient and then administer antibiotics just to make sure that there isn't a delay in like the treatment or the case of the patient. Now, for those who are undergoing cardiac surgery, prophylaxis can actually be given immediately before the procedure and then repeated during the actual procedure itself, just to make sure that like serum concentrations have been maintained, and then continued for 48 hours post-op. So instead of just being the one-time big-time dose prior to the procedure, there is a difference when it comes to cardiac surgery patients. So that would be all for our presentation on infective endocarditis. Thank you guys so much for listening, and hopefully you guys learned something. God bless everyone.